We now move on to the next presentation by Dr. Aby Koshy, consultant in reproductive medicine and surgery at Sunrise Hospital, Cochin. He'll be speaking on the topic Aphrodite criteria in male infertility. Let's welcome Dr. Aby Koshy to the stage, please. Over to you, sir.
A very good afternoon to all of you. For a post-lunch session, this is a very dead serious topic, and I hope I would be able to keep you awake through the whole session. So my talk is on the Aphrodite criteria in male infertility. Now, infertility is a common problem, and as you all know, the male factor is a very important part of infertility per se, which could be either as a contributory factor or a main responsible factor also. Now, though there are textbooks written on the chapter of male infertility, we know that for most of us here, as well as for most patients, evaluation of male infertility begins and ends with the semen analysis. Now, this is quite unfortunate because as a clinician, we end up overlooking a lot of other factors which might be contributory to male infertility. And as long as all of us believe that ICSI can solve all problems of male infertility, we will not try our best to actually unravel all those minor things which can be treated and avoid a major treatment like ICSI. So this approach in the fact that we are seeing a lot of new papers on the endocrinological aspects of male infertility coming up. If we keep on ignoring that, we would not be progressing in our approach to making male infertility a treatable option for many of our patients. So this is what it summarizes. Though a complex clinical condition and the fact that there are difficulties in finding out what is the best treatment option, we have to come out of that thought that ICSI is the solution for everybody and look at the nature and causes of male infertility through this paper. Now, when you look at the causes for infertility, each book or each paper will come out with different classifications. There is no uniform classification. This is one of the simpler ones which looks at what could be the cause. And when you're looking at a more specific cause, something like this, which is based on the end organ where the cause of infertility is there. So a much more elaborate way, and this also includes the ICD criteria also. But when it comes to practice and we just look at the more basic causes, we find that in nearly 50% of the cases, the male parameter looks absolutely fine. That means there is no clinical problem. The semen analysis is absolutely fine. But you'll have a very big group, which is that idiopathic group, nearly 25 to 26% of patients, where you have an abnormal semen report, but you don't know what is the cause. And these are the patients who also ask you, doctor, why do I have a low sperm count, or why do I have a problem, and why don't you tell me what exactly the cause is? And this is what we need to look into when you're looking at the Aphrodite criteria. So the paper came in RBM Online, and it was written by the esteemed urologist and andrologist Sandro Esteves and his colleagues. The group is mainly the same authors which came out with the Poseidon criteria a few years back. And Aphrodite is a pseudo acronym which stands for addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. Now, some of you might be aware that Aphrodite is the goddess of fertility, sexuality and procreation according to the Greek mythology, and is the female counterpart for Poseidon. And when it looks at trying to find out what the treatment is, we are looking at areas which are the known areas to going to the unknown areas. And the proven treatment in hormonal treatment for male infertility is classically the gonadotropic hypogonadism, where we know that a certain treatment protocol works, and this is able to ensure that the man has a child with treatment. But there are a lot of unproven areas. Does hormonal treatment really work in men with idiopathic oligospermia or with non-obstetric azoospermia? So we have tried these treatments, but do they really work? And are these treatments justified? That is something which they wanted to find out. And the reason they could not come to a clear answer is because of the lack of good randomized controlled trials. Most of our treatments, unfortunately, are empirical. Anybody who comes with a low sperm count, we just give a concoction of medicines which might or might not work. We really don't know which medicine should be given to which patient. We have a limited knowledge about what is the cause for this male infertility, and all the papers which are there really don't go really into the outcomes. Is it really going into an improvement in sperm count, or is it going into a pregnancy outcome? So these are gray areas which we need to address, and this is what the paper tries to do. So it clearly understands that there is a huge unmet need for treatment for male infertility, especially the word customized treatment according to what the problem is. And it groups these patients into 5 subgroups, more on that later, and tries to find out which treatment, especially hormonal treatment, will work for each group. So this stratification will help those scientists and clinicians who are interested in male infertility to find out what is best, and also to communicate these findings to a common pool so that we all can sit and research together and find out what is the best treatment outcome. And the collaborators for this study are the andrologists, the reproductive urologists, and gynecologists who are interested in ART. The focus area being male patients who want to have children and who would like to have an improvement in their semen quality and quantity. We would like to outline these phenotypes more precisely and come to clear communication of the outcomes of treatment, and also to encourage further clinical research and try out new pharmacological methods to improve treatment. And as with any clinical condition, it's important to take a proper history and do a proper physical examination along with 3 basic investigations. So you're not looking at a very elaborate evaluation. You're looking at a semen analysis by the latest criteria, an FSH estimation, which is a marker of spermatogonal situation, and the total testosterone level, which is an indirect marker for the intratesticular testosterone, which is the actual and the more accurate marker. And once you have this data, you classify the patient into 5 of these groups. Now I'll be coming to each group in a bit more detail. Group 1 is something which we discussed before, that is a hypo group, which could be both acquired and congenital. Acquired is classically the Kallmann syndrome, whereas that was a congenital. The acquired would be the different ways where you could do it. It could be drugs, infections, tumors, trauma, exercise, substance abuse, and even systemic diseases. This group is comparatively a much smaller group in the spectrum of male infertility, and we do encounter like an odd case here and there. So many of us might not even have seen such patients. And what is classically seen is the low FSH and LH levels, the low testosterone levels, and the reduced semen analysis parameters. Treatment is clear cut. If your GnRH pump is available, which is done in certain countries, you could try that because that's the most physiological way of restoring testicular function. If not, you are looking at HCG along with FSH. Group 2 is something which many of us see. This is probably the biggest group with low semen parameters but a normal hormone profile. And it might account to as low as 15 to as high as 60% of men with infertility. So an abnormal semen analysis but absolutely no findings on clinical examination or lab test. This group also involves a small subgroup of men with non-obstructive azoospermia who have a normal FSH and testosterone level. Now the hypothesis behind this treatment for this group is that they are probably a group of men who have a relative hypogonadism due to a reduced gonadotropin action. So if your hormone concentrations are normal but they are functionally insufficient to give a proper spermatogenesis. So adding an exogenous FSH might help these patients. Now that was a theory, but do we have data to substantiate that? Well, let's look at what is present. This was a first of the earlier analysis, which was in 2013, looking at the Cochrane library on the gonadotropin used in idiopathic male infertility. And they came to the conclusion that even though there might be some studies which show some benefit, the data is purely insufficient and we need large multicentric trials to come with adequate data. Coming to 2020, this is a meta-analysis of those studies which happened after that mostly, and they found that adding FSH could be a treatment option. But what was seen was that it does improve the sperm concentration, total count, progressive motility, but there was not much of a change in the normal forms. And there was a differential outcome based on the dosage of FSH. Now, when you're giving a low dose FSH, you would just improve the sperm motility. Whereas if you went to the higher dose, which is quite high, it could be something like giving 150 units on a daily basis, which might sound a bit uncomfortable for our scenario. But that was a dose which led to an improvement in sperm concentration, total sperm count, and motility. Now, this might be difficult in a practice when the patient has to pay for the patients for the treatment. But this is a study from Italy which is a country where the treatment with FSH for a man with a serum FSH value less than 8 is treatment is taken care of by the health services. So you don't really have to pay. And they did a not so ideal study of 194 men, a retrospective study, where 150 unit of FSH was given 3 times a week for an average duration of around 9 months. And of this 194 men, 43 of them fathered a child, half of them naturally and half after ART. And what was seen was there was a fairly good improvement in sperm concentration of normal zoospermia, as well as a reduction in the azoospermia rate. And cut down to 2023, STS came out with this interesting paper. What they found was that in men with idiopathic oligospermia, giving FSH would lead to at least 1 in 7 patients leading to a pregnancy. So that was fairly okay. 1 in 7 might sound pessimistic to a lot of us, but it did lead to a pregnancy. But when it comes to azoospermia, where the FSH levels are normal, you wouldn't have much of pregnancies, but it could improve the chances of sperms coming in the ejaculate, thus avoiding an invasive procedure, and also an improvement in sperm retrieval rates during surgical sperm retrieval procedures for ICSI. Group 3 is the one which has a lowered semen analysis, normal FSH, and reduced testosterone concentrations. Now this is considered group 3 is considered a subgroup of group 2. And the theory is that this might be men who have an polymorphism of the FSH receptor gene or allelic variants in the gene, leading to a low testosterone concentration, and it might also indicate probably a low LH level also. And they felt that this is a group which might benefit from hormonal therapy, which contains both FSH and LH activity, which in practice means giving HCG also. Now, when this group of men who had especially a need for sperm retrieval came into the picture, a very high number of patients, in fact 17 patients, had to be treated to achieve 1 additional positive sperm retrieval. So not so optimistic there. And when you looked at the subgroups where men might be the better candidates, they found with men having azoospermia and a histopathology report showing maturation arrest or hypospermatogenesis were the ideal candidates for such treatment before sperm retrieval. Group 4 were the men with a low semen parameter, raised FSH, and a normal or low testosterone level. These are classically the men with non-obstructive azoospermia, which we commonly see. And because of the high FSH level, we know that the endogenous gonadotrophins probably are not really effective in stimulating the Leydig and Sertoli cells to produce the sperms. And this is where gonadotropin therapy, ideally with HCG, might help, because that is a hypothesis in this group. And some studies have shown that there is an improvement in sperm retrieval, especially when you're going for surgical sperm retrieval. Now, unfortunately, the data here is quite weak because you don't have any large studies, and most of the case reports are either 1 or 2 patients or a small group of patients. And this is not really enough to really come into the recommendation that these treatments are going to work. But again, an area which definitely needs more research. The final group are the men with unexplained male infertility. This is a controversial statement because if you look at these men, they have a normal semen analysis, they have normal hormones, they have no medical history, and their clinical examination is absolutely fine. So to label them infertile is also a difficult situation. But many of them have wives who also have no problems, and we really don't know what is wrong. And classically, these men are not usually treated. Now, the authors came to an interesting hypothesis. They felt that in these men, what happens is that the woman gets into either superovulation for IUI or hyperstimulation for IVF. So why do you want to leave the men alone? Let's also stimulate these men with FSH so that they also have a from a normal semen report to a super normal semen report, so that they also optimize their chances of pregnancy to the maximum. Now, this is just a hypothesis which has come by this paper in 2019, and really we don't have any data to support this, but it's quite an interesting observation. So these are the 5 groups which are there. Now, this is a paper from 2024. We really don't have much of follow-up from this paper to look at what really happens in the real world. And what we really have to take home is that the Aphrodite criteria is really a novel idea about putting men into different groups so that we know what works for them. It's too early to say what is going to work, but we have some idea that unlike men who have a very clear cause like infection or obstruction, we need to group patients into different subgroups so that we can classify their treatment and research so that we find out what is best for them. And though the hypothesis right now is to give certain treatments to each group, we know that this is quite early in the field of research, and maybe in the next 5 to 10 years we will know what really works best for them. And it's not just about which medicine will work, but how it will work, and this will really come from proper big data, and it will encourage further discussion, research and feedback so that we are able to give men treatment based on what they really have as a problem rather than the sort of blind treatment we follow right now. Thank you for staying with me.
Thank you so much, Doctor, for that informative and thought-provoking session.